Hello, everyone, and welcome to the first video in our series on Grounded in Science, Centerstone Conversations. My name is Frankie Fachilla. I am the Director of Clinical Education here in Centerstone's Institute for Clinical Excellence and Innovation. And I am also the project director of the Workforce Wellness Grant at Centerstone that we got under federal funding of HRSA. And that's why I'm so excited to be talking today with Kathy Lisborg, who actually used to work at Centerstone in the Institute in the Implementation Science Department. Currently, Dr. Kathy Lisborg works at the Education Development Center. She holds a doctorate in social work from the University of Buffalo with a focus on implementation science. She's also one of us. She is a licensed clinical social worker in the state of New York. And currently she works on both suicide prevention and system-based solutions to the epidemic of burnout, compassion fatigue, and trauma that we know is really endemic to all of healthcare and behavioral healthcare in particular. Welcome, Kathy.
Thank you. I'm so glad to be here.
So grateful that you took this time to talk with us and share a little bit of your expertise. I'm just going to jump right in just for the sake of time, and something that's really on my mind. Like when I read your bio, I thought about this. We think of like suicide prevention on the one hand and burnout prevention on the other hand sometimes, but you're working with both in some capacity in your current role, it sounds like. And I wondered if you could talk a little bit about just the intersection between suicide prevention and burnout prevention.
Sure. So I think that lots of people who start in behavioral health and even in healthcare think of suicide risk and thoughts and behaviors related to suicide as only connecting with mental health. So lots of people think that if I am suicidal and I have suicidal thoughts and I've attempted or I'm thinking of attempting or making a plan, that I must be depressed or have some underlying mental health issue. And it really isn't always the case. That there are a lot of risk factors that go into suicidal thoughts and behaviors, and burnout can be one of them. And we've seen, particularly related to COVID, many doctors and nurses dying by suicide that really are related to burnout, moral injury, and the trauma that they have experienced, particularly during the height of COVID. But it remains that they are still at high risk, and there are higher numbers of healthcare workers that are dying by suicide. So the combination really makes sense when you're looking at burnout also as burnout prevention or burnout treatment, but like helping to ameliorate burnout symptoms in people is going to also be suicide prevention work.
Yes, that makes a ton of sense. And it also just, I feel like this is something that I learned from you, like when you were here at Centerstone too, is this idea that it's not like a game of whack-a-mole where it's like, okay, let's fix the suicide piece and then move on. And my clients over here, and they have suicidal thoughts and I never do because I'm the provider. Like all of this can get really, we're all people, right? And so we're all struggling with the same things, and we're all living in a world with a ton of systemic stressors and really unsustainable factors going on right now in our current world and economic system. And so I think it's really interesting and actually helpful to me to think about that as just being like, we're all kind of we're all in this together, like our clients, our staff, everybody, and feeling that burnout can really drive up like even existential concerns, right? Of like, why am I even here? Like, if I can't do this job, like, what am I doing? And really thinking about suicide in a passive or active way.
Yes. And I think particularly behavioral health and mental health, or behavioral health and healthcare, work in those siloed, work in a very siloed way, right? Even if you just think of healthcare, like you've got cardiology, you've got pulmonology, you've got allergies, you've got primary care, and they don't always talk to each other. And they often think of like, oh, well, you need to go get that taken care of before you can do this. And so the same in mental health and behavioral health, we used to think, well, you've got to go take care of that substance use issue before we can take care of your mental health, not realizing that they are overlapping. And the same with suicide prevention. We think of it as a public health concern, which, you know, spreads across all different areas of healthcare, behavioral healthcare, schools, even just regular, you know, business, manufacturing kind of workplaces. When you take burnout into consideration, suicide prevention should be in the mix.
Yes. Yeah. And it's partly why with the workforce wellness grant, one of the pieces of that was providing suicide prevention training to like EAP providers, which is, you know, the people in theory that may provide health, mental health care to our staff too. So that all makes good sense to me. So broadening our focus just a little bit from thinking about suicide, you have so much great expertise on workforce wellness. And I wanted to just say, like, in general, what if a company is really focusing on workforce wellness, like, what does that look like? What does it include?
So I think, to use a metaphor, I think an organization that's going to be looking at workforce wellness is essentially like emptying out that really overwhelmed, overstuffed closet. And they're spreading out all of the things that they're doing, looking at all of them and seeing if they actually work, if they're actually doing what they want them to do. Like, are they getting the outcomes that they want? And this is also looking at their workforce and not their clients. So I think many organizations really just focus on client or patient or whoever the individual is that they are serving. They're looking at those outcomes, and the worker outcomes are really second. So first, they're focusing on worker outcomes, and worker outcomes that also include leaders. Like, we often think also that leaders are like over here and workers over here, and we want to focus on workers, and leaders need to suck it up and just kind of power through. But in reality, we're all humans, right?
Yes.
So pulling all that stuff metaphorically out of the closet, looking at what works, and then organizing it in a way, and this is all just sort of a metaphor, but then also looking at what else is needed. Because of a lot of the systemic work is complex and nuanced. We don't necessarily have an intervention that has a manual, and I can hand that to you and say, do this and you will be fine, and all your workers will be happy, healthy, and productive. And so when you look at the research that's coming out of post-COVID, oh my goodness, so many people are overwhelmed and traumatized and burned out. The majority of the research shows these nuanced, subtle changes, cultural changes that are really hard to quantify. So I think if you look at an organization that's actually doing it, they aren't afraid of that complex, nuanced conversation.
Okay.
And you might not even see, if you looked at an organization, you might not always see the signs of what they're doing, because I also think a lot of it is sort of, it's going to be done behind closed doors, or like in the thoughts of leaders. I need to think about what I'm saying. I need to think about what I'm doing and try and do it in a better way, in a way that increases collaboration, increases, values feedback from workers, and then does something with that feedback.
Yeah. Because it seems like as you're taking things out of the closet and looking at them and evaluating them, you need as a leader, you need a perspective other than your own on the item of clothing. Like, I don't think you've worn this since summer 2007, but actually maybe somebody has been wearing it and you just didn't know.
Right. One of the programs that's out there from the AMA is called Getting Rid of Stupid Stuff. And so, I mean, if you think of that, like using the closet metaphor of like, I'm not using this, this doesn't serve us anymore. This doesn't work for us. This actually creates problems for us. Can we stop doing it? Do we really have to do it? And then to connect with implementation science, we have like, you can de-implement something and it should be sort of a thoughtful, not just let's throw it out because I don't think it works, but like a thoughtful process to look at something to determine, is this not working? Is this working or is this not working? One of the things that I really suggest that people do too is evaluate whether your policies are working. You have a policy to do something, maybe to improve the well-being of workers, or something that's related to diversity, equity, and inclusion. Well, is it working? You won't know unless you really do some sort of evaluation.
Yeah. Yeah. And this also brings up a question, because something that we hear a lot across our system and in leadership as well is really the capacity to even have time to like sort through the closet and take everything out and look at it is really limited. And so this thoughtfulness that you're talking about, kind of bringing not a sense of urgency, but a sense of let's really take a step back and look at the contents of the closet and think through them, I think is a real struggle sometimes when you have a existing culture maybe at the organization where it's really fast paced and there's not any time or space to process or think beyond a string of meetings or tasks that you have to get done.
Yes. And I also think that sometimes that reason that we don't have the resources or we don't have the time, particularly we don't have the time, could be rephrased of this isn't the priority. So looking at organizational priorities and really having that conversation of, do we really need to do this to keep the lights on, to literally keep the lights on? Or is there a cushion in there that we really want, but maybe we can let it, diminish a little bit in order to prioritize these other things that we know in the long run will improve the bottom line, will improve productivity. But having that priority, it's, if you think of just personally, sometimes it's hard to let go of what you always have done, even though that that's going to be better later on. It's just going to take a while to get through it. So I find like people that say we don't have the time to do it, it's not a priority, and maybe looking at the priorities and reprioritizing them.
Yeah, so it's almost like thinking of this as its own priority is what I hear you saying.
Yeah, and maybe more of a priority than something else.
Yeah. Could we really think about the detrimental kind of domino effect that having a burned out workforce could be causing in our system, and then reprioritize this over something else that's hard, but it feels important.
And the other concept too, and so I work with zero suicide, and zero suicide is sort of that aspirational goal. But we talk about when you aim for zero, when you aim for perfection, even though in some aspect of your brain, you're not going to make perfection. But when you aim for it, your attitudes, your behaviors, the way you're working the problem is going to be different than if you're just aiming for a 10% reduction in the burnout of your staff. Like if you're aiming for no burnout, healthy, happy, productive staff members that love to work here, that's a different than, okay, we just want to improve their, by 25%.
Interesting. So it could be a attitude shift that could be positive, to think of it like we really want our whole workforce, our entire workforce, to be happy and healthy when they come to work.
Right. And having that, and maybe that answers the second part of that question, in that an organization that really is aiming for everybody's happy, everybody's feeling productive and really enjoys the job, maybe that's what you'll see if you're looking at an organization that's really doing sort of all the work.
I feel like that's a good segue into another question that I had one of the aspects of the workforce wellness project we're doing at Centerstone right now is this idea that you really pioneered and started when you were working here last year, which was this trauma-informed kind of behavioral guide. We call it a practice profile on the project, to think about like, how do we treat each other? Like as staff members, how do we treat each other? What am I doing to be trauma informed towards other people here at work, not just towards clients? What are leaders doing? And that almost feels like maybe perhaps like when we're saying, what does it look like? What could you observe about an organization that's working in this way? I wonder if those trauma informed kind of person to person behaviors would be part of that.
Absolutely. As you know, that's like one of my favorite things to talk about. Yes, you would, how are you supporting your peers? Like if you're a supervisor, how are you helping the people under you be good teammates? How are you building a good, solid team? Because we know that when a team works really well together, your productivity is higher, your clients are doing better, your workers are doing better. And then how are you, if you think of using the SAMHSA principles, empowerment, voice, and choice. So how are you empowering your coworker or your supervisee or the person, in the ladder there who's under you? How are you listening to their voice, encouraging them to express themselves, offering them choice? And, there's not a lot of research about the mechanisms of burnout that will work to improve outcomes, just because it's hard to research something that's sort of elusive. But flexibility and autonomy have come up over and over again as things that are important to help people reduce burnout or avoid burnout. So if you're giving people choice, then you're giving them autonomy, or you're promoting autonomy, and you're encouraging flexibility, and then all the other ones. And then that's going to lead into people feeling safer, both psychologically safe and physically safe.
Yeah. That makes a lot of sense, and it aligns with sort of the model that you probably remember that we're using for the grant, which is like demand control support, or how do I increase people's control, increase the support that they feel from maybe the people they immediately work with more than anybody else, but also from executive leadership. And then how do I help that person reduce their demand, or reduce the demand that's driving burnout for them? Because some demands may be positive, other demands may just be driving up stress and burnout. So that's really cool.
Yeah. Another thing too that that I found in the research was when there's that disconnect between sort of the mission of the organization and the mission of, say, the profession. So I'm a social worker, or also licensed mental health clinicians. If we're working in a clinical setting, our goal is to be able to support our clients. And if the mission and vision of the organization is also to support our clients, but they're not doing that, they're not providing us the environment and the resources to support our clients, that sort of is that mismatch between my why, the organization's reported why, and what actually is happening. So when you can align those, and then people also can do more work under less than favorable situations or environments, because the why is there and they're able to do that. So for example, I had a client who had her first manic break, and I spent way more time than I should have, but my organization at the time was very supportive. And so burnout didn't happen because I had that additional support, even though I was doing more than I would normally have done with a client given the circumstances.
Yes. And that makes so much sense, that through line. I could really see it when you were talking just then between client care and workforce wellness, right? Because I actually ran across this term in the research. It's called pathological altruism, where it's like maybe my organization isn't supporting me, but I'm like throwing in like all of myself to support my clients. And it can become just like very self-sacrificial versus really feeling that support and through line for the mission that's supporting me as a staff person.
Yeah. And I've seen compassion fatigue described that way, of like both that disconnection and over identification with your patients or your clients, and like, you know, not just going the extra mile, but going the extra 100 miles.
Yes. So I know we're about at time. I could talk to you all day, but I did want to wrap up with just one question. Let's say we have a lot of like newer people to the field at Centerstone. If you're a new employee just kind of starting off your career in mental health, what do you think someone should know about burnout or resilience at work?
I mean, I think it's hard to recognize what will burn you out until you're in the middle of it. So I think like recognizing that giving new social workers, new counselors, new people in the field, the education of what is burnout, what is compassion fatigue, what is trauma, what does it look like, and then having a really good supervisor who understands how to help somebody determine what helps them avoid burnout, which might be different for other people. We often think of like, you know, taking breaks. You know, a supervisor is make sure to take your lunch, make sure to leave at the end of the day, don't take work home. But somebody might actually benefit more from that autonomy and that flexibility, and the supervisor checking in with them and saying like, okay, how are you doing? I trust you and I want to help you. I'm not going to micromanage your environment, but I'm going to check in with you regularly to make sure you aren't missing some signs. You know, you aren't missing where you're starting to feel overwhelmed. Because a lot of times, right, you know, we don't realize we're in the boiling water because we started there at the very beginning. So I think it's in recognizing that self-care looks different for everybody.
Yeah.
You know, it's not manicures and coffee and massages necessarily. It is for some people. Other people, it's healthy boundaries and saying no.
Yeah. And really personalizing it, it sounds like, is the key. And really allowing yourself to be human in this work first, and really honoring like that what looks one way for you may look different to the person that works in the office right next to you.
Yeah, I recently heard somebody talk about that related to soccer, actually. And it was so you think of like women's soccer, they're playing the World Cup right now, and you need a really cohesive team in order to win. But each individual player needs to be their own authentic self in the work in order to be the best team. So the same way, like we need to be able to value our own humanness and be our own authentic self in order to be able to be that counselor, that peer support worker, that nurse practitioner, or anybody who is helping other people. We need to be able to, and the organization needs, and that sounds like individual work. The organization needs to put in place ways that promote and support and value those authentic individual human beings that work for them.
Yes.
To create healthy teams and a healthy organization.
We're people first.
Right. Right. And like, that's what our work is supposed to be, person first.
Yes.
But our workers often are left behind.
Yes. Well, that's a perfect note, I think, to close on. Thank you so much, Kathy, for talking with me and offering some of your valuable expertise to this video. And I hope that if you've been watching, that it's been helpful.
Thank you. I appreciate you including me. It's been fun.